Thanks, Kathy. So it gives me great pleasure to introduce three colleagues and very dear friends, Sarah Gillespie-Heyman, Sofia Simona, which we call her Jakab, and Susan Zapatka. So all three of these phenomenal providers practice at the VA Connecticut in West Haven. They have actually developed a lot of programming around palliative care for our patients. We actually have a co-localized clinic, which was really envisioned by Simona. I want to kind of tell you a little bit about each one. So Sarah is an APRN, and she does a lot of palliative care for the oncology service, but was willing to expand her horizons and come and actually co-localize with us in liver clinic. And our patients have benefited immensely, and we have learned a ton from her. Simona, as you know, has lectured to us on many occasions. She's an associate professor at Yale and a staff physician at VA Connecticut. She's done a lot of quality improvement to really make our clinic co-localize with not just palliative care, but also with addiction medicine. And she's done a lot of outreach to primary care providers to really broaden our catchment and our reach. Sue Zapatka is also an APRN. We were lucky enough to recruit Sue from primary care, where she took a huge role in developing the VA Center of Excellence in Internal Medicine. She loves working with trainees, both medical residents and APRN students. And she has really embraced this co-localization of palliative care into our clinics. All three of them have been master recruiters for a national study looking at palliative care and its delivery to patients with liver disease, and whether that palliative care is better delivered by a palliative care provider or a hepatologist. That study, the PIs are Victor Navarro and Manisha Varma at Einstein, but we are one of the 14 national sites. And so as part of that work, they really want to tell you about what they've been doing, but it's really important to understand that we're making great inroads in research in palliative care and liver disease, and I'm sure they will share with you their enthusiasm and their insights. Thank you all three for speaking tonight, and I wish we could all be together, but it's wonderful to see you virtually.
Thank you so much, Tamar, for that wonderful introduction. Hopefully everyone can hear me well. I'm here with Sue and Simona. We're here at the VA, and I'm going to start off our presentation. Next slide, please. So we divided it up into 3 sections. So I'll be starting with talking about palliative care myths versus facts, and then Simona will follow and Sue will follow her. Next slide. So palliative care myths versus facts. Next slide. So one of the biggest misconceptions that I think both providers and patients and families have is really the differences between palliative care and hospice, and how a lot of folks equate palliative care with hospice care. We do not equal hospice care. We can help facilitate hospice care, which I'll talk about in a little bit. But I like to think of us as a precursor and really a support team that comes in prior to somebody's end-of-life care. And I think that's why having palliative care involvement is so important in our patients and our families' lives, our patients' families' lives, so that we're not coming in at the very end, but we're really forming that bond and relationship with them prior to end-of-life care. Next slide. So the World Health Organization has a very concise and I think pretty adequate definition of what exactly palliative care means, and it's written out here, but really it's an approach that improves the quality of life for patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. I like to think of us as a well-rounded team. You know, my team here at the VA and most palliative care teams include multiple disciplines. So there are nurse practitioners, physicians, social work, psychology, chaplaincy, and we even have a pharmacist that helps us out on occasion as well. And I think having all of those disciplines involved really benefits the families and the patients in order to give them the best support possible when they're dealing with these life-threatening illnesses and all of the physical symptoms that occur with them, as well as the psychosocial and spiritual issues too. Next slide. So who to refer to palliative care? So specifically within the liver clinic is what I'm speaking of at this point. As Tamar said, primarily palliative care providers can be found with oncology clinics and, you know, with oncology diagnoses that we are helping out with. But I like to think that it's not just oncology patients that we help as well. And so here at VA Connecticut, at least, we are embedded in multiple different clinics, and liver clinic being one of them. Since COVID, things have had to change a little bit, and you know, it's more of a virtual presence via telephone and video telehealth, but we're still heavily involved in that clinic. So folks with end-stage cirrhosis, including those considering transplant, should be considered for referral to palliative care, as well as patients who have refractory cirrhosis and symptoms that, despite treatment after treatment, are not helpful. You know, recurrent ascites, recurrent variceal bleed, for instance, or hepatic encephalopathy. Unintentional weight loss. So this is a greater than 10% of body weight in less than 6-month time period. Liver cancer, especially if they're having frequent procedures or referred to oncology for systemic therapies. Patients who are experiencing particularly psychological symptoms like anxiety, depression, existential distress, and it could be related to their diagnosis, but it could also be other factors that are being considered, like if they have a history of PTSD, for instance, which is very common in our veteran population. And finally, we're not just looking at the patients who can gain our support, but also the families. You know, the caregivers, I think sometimes, and I am guilty of it as myself, we forget how much caregiver burden and distress can occur trying to take care of somebody who has a life-limiting illness. So I think we as a team can support them, and that would be somebody to refer to palliative care as well. Next slide. So the definition of hospice, and this is by the National Hospice and Palliative Care Organization, is really compassionate care for people facing a life-limiting illness or injury. And really it's focusing on comfort rather than cure. So somebody who has come to the point in their illness where we know that no amount of treatments are going to potentially cure what they have. For instance, a type of cancer, no amount of chemo is going to make a difference in their prognosis. And really, we've had that discussion with the family and the patient and decided to transition our approach to really more of a comfort-oriented care, both supporting them emotionally, physically, and spiritually. And really the goal in the end with hospice is death without suffering and with preservation of dignity. You know, we only have one death, and we try to make it the most dignified and compassionate as possible. And that really is the goal of hospice. Next slide. So hospice eligibility is somebody who is in a prognosis of less than 6 months, if we're speaking of home hospice specifically. There are, though, 4 different levels of care under the Medicare hospice benefit that I'm going to speak of. So routine hospice care, for instance, is home hospice, where you have an agency coming in delivering hospice-directed care to the patient in the home. Or if they're unable to be at home and they need more skilled nursing help, in a nursing home. Intensive comfort care or continuous home care is usually in the very last hours of life, and typically speaking, It's when there are symptoms that are very challenging to control and the families are feeling much distress. And so we have the home hospice nurse go in and take shifts essentially, and they're there around the clock with the patient and family. And again, it's a very time limited approach. It's not usually longer than a couple of days at most. Respite care is really to benefit the caregiver, you know, to try to combat some of that caregiver burden that I was speaking of a little while ago. This is where a patient is allowed 5 consecutive days to come to a facility for respite. So the caregiver can do whatever they need to do to take care of themselves, and so then they can take care of their loved one when they come back home. And this can be taking place in different nursing homes. I know our facility here does have respite beds that are available to our veterans. So that is a really nice benefit, I think, for caregivers to be able to take advantage of, and should. And then finally, there's general inpatient care. And this gets a little tricky, and sometimes families don't always understand. Not everybody who is eligible for hospice can come in and be taken care of 24/7 in a facility, in a specific inpatient hospice facility. It's not meant for people who are dying without distressing symptoms. So if they have no distressing symptoms, they don't qualify for this inpatient care. So it gets a little tricky sometimes, particularly if the patient doesn't have bad symptoms, but is functionally declining and becoming more challenging for the caregiver to take care of at home, physically take care of. So there's a lot of discussions with families and patients regarding this. Next slide. So really the biggest differences, and I think I might be repeating myself a little, but the differences between hospice and palliative care, you know, hospice, like I said, is prognosis less than 6 months. The goal is comfort oriented. Aggressive therapies are not offered anymore. So we're not going to offer chemotherapy to a patient who is on hospice care. And again, it cannot coexist with curative treatments, like I said. Whereas palliative care can happen at any stage of illness with symptoms that are distressing. So I can meet somebody who was just diagnosed with cirrhosis, for instance, who maybe has abdominal cramping, or, you know, perhaps is having some edema that is just bothersome and causing their function to not be as well. I can meet them right from the get-go and still be able to take care of them throughout their illness. And actually, I find that much more rewarding to meet somebody earlier on versus coming in at the 10th hour, you know, and not really getting to know them and their family and what their specific needs are. Goals are not limited to comfort, and any and all aggressive medical therapies can be pursued. So they can go and have their systemic treatments in oncology, they can go have radiation, different, you know, procedures, TACEs, etc. And it can coexist with all of these treatments. And that's something I do tell my patients to reassure them. I just had a patient today who was like, well, wait a minute, I'm also getting care for my bladder cancer. Can I not get that care any longer if I'm talking to you? And so it's a lot of education for families and patients. Next slide. So the different Medicare criteria for hospice and palliative care. So it is a standard Medicare benefit for both hospice and palliative care. The big difference, and you know, it seems kind of strange, but for hospice, homebound requirement is waived. So you do not have to be homebound. You could be going to church, you could be going to visit a family member. You don't have to be homebound. Whereas palliative care, you must be homebound. And it seems silly, but I've had to really have some honest discussions with patients and families about, you know, what their daily activities look like. Most of my patients that I do meet, I have to say, are homebound. And especially now in the world of COVID, I mean, everyone's homebound. But the other thing, hospice typically requires a 24/7 caregiver to be in the home while the patient is receiving hospice care. there are some exceptions, they're rare. Some agencies that we work with, if the patient is able to do their own care and they're safe and they're deemed safe at home, the agency will allow them to have hospice at home, but for the most part, they do want somebody else in the home with them in case something happens, in case they fall, in case they need medication that they can't handle. So in palliative care, you don't need a caregiver at home 24/7. In terms of the home care agencies, a lot of them vary in terms of their training of the staff. So hospice agencies that are specific for hospice usually have extensive training in delivering hospice care. Palliative care, on the other hand, there's a lot of variability. I find it really depends on the agency. And, you know, one of the questions, and most of our agencies we contract with here at the VA do have the necessary training, but it's not all the same. So it's just something to think about. And finally, with hospice care, you can't receive home physical therapy or home occupational therapy on a routine basis. So if the individual was receiving these services prior, they can no longer receive them once they are transitioned to hospice care. They can, though, in the initial phase of hospice, obtain a safety evaluation. So somebody can go in, look at their house, make sure they're safe, and that's it though. Whereas palliative care, those services can be ongoing. So you don't have to stop the home PT and OT. Next slide. So general guidelines for hospice care: loss of function, you have to have a life-limiting condition. For instance, pain management is not a life-limiting condition. And I have to say, very frequently our team does get consulted specifically just for pain management, and we have to defer these consults. You know, it's not appropriate. It's different services will help with that, but it really, the patient has to have a life-limiting condition. And again, the treatment goals are for comfort rather than cure. I spoke about the weight loss already. And something else interesting is repeated readmissions. So if somebody has 2 admissions for a similar condition or same condition within 6 months, or 3 admissions in 1 year for the same condition. And then finally, if they have a sudden period of rapid decline after having, let's say, a stable course of, you know, alcoholic cirrhosis or whatever, then we can have them make criteria for hospice and be eligible. Next slide. So specifically for liver disease, based from the National Hospice and Palliative Care Organization, the primary factors I look at for folks that are eligible for hospice care is somebody with end-stage cirrhosis who is not a candidate for transplant. We look at different lab values like their INR, their albumin, and at least one of the following: refractory ascites despite treatment, SBP, HRS, recurrent variceal bleed, hepatorenal syndrome, which I already mentioned, sorry, and hepatic encephalopathy despite treatment. So those are really the primary factors. Some secondary ones, which usually don't come into play as often, but kind of are part of the picture anyway, is malnutrition, muscle wasting, if they are continually using alcohol, primary liver cancer, or some of those secondary factors. Next slide. So the palliative care myths, another one in addition to thinking that we're hospice care is the fact the provider may think, I want to help my patients, not to give up on them. And that thinking this thought process that by having them referred to palliative care or hospice care is in fact giving up. And it's far from the truth. I like to think of it as, in fact, you're doing a huge service to your patient and to your families by actually having us be consulted. And, I think because in a way, the hepatologist looks specifically at the liver, obviously, and things concerning that, but I like to think of us as looking also at the whole person and the whole body and focusing on providing as much relief from symptoms and the stress of illness And also thinking about the big picture and what are the patient's goals, what are the family's goals, in having these really frank conversations with these individuals, and improving their quality of life for those with advanced illness, regardless of diagnosis, prognosis, age. So I really think of it as a benefit. And again, you know, and I say this all the time, is we're not here to take over any of your other providers. You know, I reassure the families and the patients, I'm not going to become your PCP. I'm not going to become your hepatologist. You know, you're still going to have all of those other providers on your case. And so we're just an extra layer of support. Next slide. So the next couple of slides are different common symptoms that we see with our liver patients who we follow for palliative care. And, you know, some of the more common ones, I think, you know, and again, this could be not just liver patients as well, but specifically fatigue. You know, one thing I know we have here at the VA is we have like a sleep clinic that actually kind of trains people how to sleep better. And it sounds silly, but it actually, I've referred many patients to it, and they've had quite a success with that, and just learning about their sleep hygiene. Insomnia, you know, a lot of my patients are on trazodone, even a little dose. You know, of course, we need to be careful if their mental status is not great. If they have a lot of encephalopathic episodes, then we have to reconsider, you know, pharmacologic interventions. Itching, different lotions, Atarax, etc. And again, they're all listed here. Nausea and vomiting is pretty common. So any of the antiemetics, you know, Zofran, Reglan, etc. Encouraging the patient to not eat like 3 large meals a day, but have frequent meals and often, and snacks in between. Decreased appetite. So we do work with appetite stimulants. I have to say though, here specifically in liver clinic, I haven't had to prescribe anybody with Marinol. I've actually used it more in oncology setting. And it's hit or miss. It's kind of a, you know, anecdotally, it's sometimes it works. I don't know if sometimes if it's a little bit of placebo effect, but you know, so some patients we will consider that for. Next slide. So for bloating, if they're on a larger dose of lactulose, or maybe they take it all at once, thinking about dividing the dose up, maybe adjusting the dose a little bit, using Miralax. For cramping, obviously we want to think about anything that could be going on obstruction-wise, but also pain management. One of the things that we frequently prescribe, and I know I do this not just with liver patients, but people who feel kind of that abdominal fullness or stretch, I prescribe hyoscyamine quite frequently. And I've met pretty good results with it, and with minimal side effects, which I think is important for patients also. Finally, there's ascites, of course, you know, frequent paracentesis. You know, narcotics, I rarely prescribe narcotics in a lot of these patients, just because a lot of them are having encephalopathy. If I do, it's usually tramadol, typically. But also we try to see if they can take a little Tylenol, if that will help with any discomfort they may have. Next slide. And muscle cramps, making sure that their electrolytes are in balance. You know, tonic water, actually, I've used with a lot of patients who have those like leg cramps that wake them up at night. And amazingly, it does work a little bit. For edema, we have stockings that we provide for patients. I kind of already talked about the pain. Anxiety-wise, you know, typically speaking, I don't prescribe benzos, because we really don't want this to become a long-lasting habit for patients. Actually, a lot of the times we have a psychologist here in the liver department who will talk to patients and be able to do, you know, cognitive behavioral therapy, which I think kind of involving mental health is super important as well, and same with depression. A lot of the patients already come to me on different medications that are handled by our mental health service here. Next slide. So the difference between specialty palliative care providers versus primary. So really anybody can deliver palliative care. I think, and everybody should be able to deliver basic palliative care. This includes primary care physicians. This includes, you know, the disease-oriented specialists like hepatology, cardiology, oncology. And it's not getting into the specialty support that we can provide, but it's the basic, what palliative care is, introduce it to the patient, basic symptom issues that arise, basic social support, getting home care. If needs arise that become very tricky and very complicated, then you bring in the specialty palliative care providers like myself or one of my team members, and we can help with our interdisciplinary team to support the patient and the family. But I really believe there's not enough of us. So I think everybody really needs to have some comfort level in delivering primary palliative care. And I'm so lucky to work with an awesome hepatology department that they all feel pretty comfortable delivering it. So for me, that's been amazing. Next slide. So in summary, supportive care, providing palliative care, supportive care, providing relief from the symptoms and stress of a serious illness like liver disease. It can be given at any stage of the disease, at any age, okay? It does not replace other treatments. It does not replace other providers. And it really is an extra layer of support for both the family and their caregivers and the patients. And I just think that, you know, I'm honored to be able to help people live whatever rest of life they have as best as they can. And, you know, and finally, I think at some point palliative care can help facilitate hospice care, and that's the end result, obviously. Okay, thank you. And now Simona is going to talk.
Thank you very much, Sarah. The reason why we are, I would say, reasonably good about delivering palliative care is because we've been working alongside you for all these years. So thank you for being such a great colleague and friend. So next slide. I'm going to switch gears a bit to discuss about the need and benefits of palliative care in our patients with liver disease. And very briefly, I will just point out some important facts about natural history of cirrhosis. Basically, any chronic liver disease can lead to cirrhosis, but there is quite a difference between compensated cirrhosis, decompensated cirrhosis, and nobody can say it better than Dr. Garcia-Cao. So I took the figure from one of her many guidelines when it comes to management of cirrhosis. And you can see if somebody has compensated cirrhosis, they may or may not have clinically significant portal hypertension with varices, but these are patients who are basically asymptomatic. We are getting better about diagnosing them, and these patients overall have a mean survival of more than 12 years. When somebody has decompensated cirrhosis, again, as Dr. Garcia-Cao says, you can make the diagnosis as the patient walks in the door because they have ascites, they are jaundiced, they can have hepatic encephalopathy. And the patients that we see on our liver service are patients with further decompensation of their liver disease. And in this category, the survival is 2 years or less. And without a liver transplant, these patients will die. Next slide, please. And that's why, again, it's very important to talk with our patients and our colleagues. There are many phases of cirrhosis. I cannot tell you how many times the patients come back, panic, they talk with other providers, or they Google and they say, oh my God, I have cirrhosis, am I gonna die? What's my prognosis? So compensated cirrhosis is it's a much different disease than decompensated cirrhosis. Patients with decompensated cirrhosis are the ones who have many symptoms related to their disease and the treatment. And just because I'm an eternal optimist, just wanted to point out that there is such a thing as recompensation with treatment of underlying liver disease. especially we've all seen patients who stop drinking alcohol, how well they do over the years, or treatment of autoimmune hepatitis, viral hepatitis. Next slide, please. And I'm not gonna repeat what Sarah said, but actually a lot of us liver providers are actually providing treatment of many symptoms. But what we do is just the tip of the iceberg. So yes, we are pretty good about dealing with ascites, edema, hepatic encephalopathy, and so forth. But everything else that Sarah mentioned, sometimes we have tunnel vision, and we do a disservice to our patients if we don't expand the treatment team by including our colleagues from palliative care. Next slide, please. As far as the liver cancer goes, there are also many phases of liver cancer, and this is a phrase from Dr. Terry, who always tells us there is one patient but two diseases. These patients have liver cancer, but they also have cirrhosis. And a lot of these patients with liver cancer, they have compensated cirrhosis and they feel totally fine, and they don't realize that their cancer is very much limiting their survival. In addition to that, patients with liver cancer who qualify for liver transplantation and exception points can be cured through liver transplantation. So many times we have this weird situation in liver clinic when we tell the patients that they have cancer, but we sort of put a positive spin on it. You know, you have cancer, but we can get you extra points and we'll get you transplanted. So a lot of nuances when it comes to patients with liver cancer as well. Next slide, please. There are also many problems and challenges that our patients with liver cancer face. So on one hand, we sort of keep treating them because we hope for a transplant in the future. So they undergo multiple procedures, they get hospitalized for multiple complications. And in patients who have liver cancer and decompensated cirrhosis, sometimes it's hard to tell them if there are no transplant candidates, there are really no significant treatment options. Next slide. So another big challenge that we face, both talking to our patients and other providers, is how we estimate the prognosis for our patients with decompensated cirrhosis. Next slide. We do use the child score, and I won't go too much into detail, but basically the child score can give you a glimpse into the future at 1 year, 2 years. So as you can see, child C patients, they have a survival of at 1 year about 40% or so, 45% or so at 2 years, less than that. Next slide, please. And also the MEL score, which now is mainly used for organ allocation for patients who are listed for transplant, can give us an idea about our patients' mortality in 3 months. So if you punch in the numbers and you get a MEL score of 35, as you can see, you have our patients face a risk of mortality of 80% or so in 3 months. And these scores, we use it, but this is not an absolute way to tell patients, okay, this is what is going to happen. These are tools that can that allow us to put some numbers to advise our patients, but by all means, these are not absolute measures. Next slide. The other challenge that we face, we as providers, but especially our patients and their families, is the fact that cirrhosis does not have a linear progression. So you cannot say, you know, in 3 months, this is what's going to happen. In 6 months, you're going to get worse and so forth. They do relative okay, then something happens, they get an infection, they get bleeding, they end up being hospitalized. Some patients recover, other patients continue to decline. So the only thing that you can reliably predict about cirrhosis is that it's very unpredictable. Next slide. And just on a side note, for us who take care of patients waiting for liver transplant, unfortunately, as much as we try to get patients to these life-saving procedures, good things don't really come to those who wait, because out of roughly 18,000 patients waiting for transplant, 1/3 can die while waiting, because in the United States, we get only about 6,000 transplants a year. And for these patients, life can be quite a hell, because they are in and out of the hospital. They have to undergo invasive testing procedures. Their family is under stress because they are asked to produce living donors. They undergo evaluation and so forth. Next slide. And that's why I just wanted to stress out how many challenges our liver patients have to face, related a lot, not only to their symptoms and stress because of their disease and treatment, but there is a lot of uncertainty how they will progress in the future. Can they get a liver transplant? So it's very important that sooner rather than later we talk about the realities of transplant in terms of donor shortage, high MELD, too sick to transplant. We discuss transplant versus fertility, and we also keep in mind patient and family burnout given all these intensive procedures, readmissions, and so forth. So I hope you can very clearly see how many benefits our patients can have from palliative care. Next slide. So the other thing that I want very much to impart is that our palliative care colleagues work alongside with us in liver clinic, and this is not a very clear line. So it's not, liver care happens until a certain MELD point, and then they get palliative care. So we work together, it's all interconnected. So patients who receive palliative care, they also receive liver life-saving interventions. And it's a team approach that ultimately benefits the patients and their families. Next slide. Without going too much in reviewing the literature, I just wanted to point out to two recent papers. And luckily, there is so much growth in this field over the last 5-10 years. But especially when we consider patients for transplantation, these patients, unfortunately, they are really not offered palliative care, and they suffer throughout with lower quality end-of-life care. They have longer hospital stays. They are more likely to receive aggressive, life-sustaining treatments that end up to be futile. And one of a very interesting study from our colleagues in Philadelphia at Einstein showed that an early palliative care intervention in patients referred for liver transplant evaluation improved symptom burden and mood. Next slide. We were very lucky to collaborate with Dr. Tandon from Canada, and she was invited. She was the inaugural speaker for Dr. Garcia Cao's lectureship. And we are using on a regular basis her clinical experience in clinical practice of combining palliative care and hepatology care. So I very much advise you to just take a look to her. Her review has a lot of best practice tools, a lot of visual aids, educational resources. And just as an example, next slide. She can give you, by using that review, you have access to very simple ways to start the conversation with your patients about cirrhosis, severity of cirrhosis, planning ahead their healthcare, discussing their goals of care. Next slide. And also discussing, potential scenarios for the future, especially in regard of how unpredictable the cirrhosis course can be. Next slide. So just as a summary, what we are usually doing in our liver clinic, so not everybody who walks in the liver clinic at the VA with cirrhosis, they get palliative care, but this is when you can sort of touch upon that the disease can progress. Of course, we are here to help you and so forth. But when somebody has decompensated cirrhosis or they develop liver cancer and they end up having multiple procedures, it's very important to have a sit down with the patient, their families, to try to discuss in more detail about their function, possible functional decline, disease progression. And when unfortunately these patients get to end of life, they are already lucky to have our palliative care team alongside them for years, and the transition to a good death, it's easily achieved. Thank you. And next slide, because our we saved the best for the last. So Sue is gonna tell you exactly how we act in the liver team.
So thank you, Simone and Sarah. I have the pleasure of working alongside all of this amazing team. So the expertise that is available to us on a daily basis and to our patients is just incredible. So next slide. So this slide spoke to me from the beginning in my learning and mentorship from Simona and Tamar, and then in my workings with Sarah. So a picture can say 1,000 words. So when you look at palliative care, we realize that we are reaching out to improve our communication with our patients and families. We're reaching out to have a whole team approach to offer more accurate interventions, that we want to develop the compassion amongst each team member with the patient and the caregiver or the family as the actual core or the central focus. We want to decrease suffering as much as possible. And what we learned, despite COVID-19, touch still remains a very paramount means for caring, and patients and family do require this. Next slide, please. So as Tamar had explained, we in 2016 developed co-localized weekly clinic. It allows our patients to come in and see a palliative care team provider and a liver clinic provider at the same time. So it's kind of that one stop, allowing them with enough stressors that they go through on a daily basis to have this opportunity. So when we look at palliative care, I know you've heard multiple slides and multiple discussions regarding who we do refer. I think as soon as that diagnosis of cirrhosis comes in, as we've said, really thinking early on and thinking what's going on. And especially as soon as decompensated cirrhosis comes on and liver cancer. So once patients have a liver cancer diagnosis, if we know we're able to potentially even have a more curative procedure, we still do want to think about palliative care. Once they're, of course, requiring repeat procedures or systemic therapy, it's really a no-brainer for us to really want to engage palliative care. And it's a very simple process to explain the benefits to the patients and families, as you've heard through this presentation. Next slide, please. So we owe it to our patients and our families to offer the best possible care. So in conjunction with other therapies that can prolong life, such as chemo or radiation, or more palliative therapies that can improve quality of life, we use this team approach to help the family and the patient cope, to offer a sense of well-being, to hopefully decrease some of those anxieties. So we really named palliative care in our clinic supportive care. And then we start off with supportive care in our discussion to the patient without even really using the word palliative at first. And that helps the patient start to understand that benefit and the family. We see patients and we have family visits so that the daughters, the sons, the wife, the sister, even the neighbor that's their friend, go back please, will also benefit from this discussion and make that decision in adding that support layer to their care plan. So our ultimate goal is to enhance the quality of life and decrease their suffering. And also, as Sarah had mentioned, we want to plan towards the end of life care as well. Next slide, please. So I'd like to say this is a patient family that we have journeyed with since I joined with Tamar and Learning in 2014-15. So it's a 92-year-old male veteran with chronic HCV. He did not have cirrhosis and did not, as he passed, he did achieve SVR. He was admitted in July 2020 with worsening abdominal distension. The veteran was in the community in June 2013 and had a ruptured 9-centimeter liver lesion that required emergent embolization, and it was found to be hepatocellular carcinoma. He transferred his care to the VA in September 2013, where he was reimaged, and the lesion had decreased in size to 6.8 centimeters. In January 2014, he still luckily had no active disease at that time. Next slide. I'm going to continue the timeline and then go into the story. October 2014, he developed recurrent disease. December 2014, he underwent a TACE. There was no residual or recurrent disease. January 26, recurrent emerged. February 2016, again TACE. Follow-up imaging showed no definitive recurrence until June 2018. Again, TACE was recommended. Next slide, please. So this is a veteran who lives alone in an apartment with his wife. He has a son who lives very close nearby, just 5, almost 6 minutes away from him. His son owns his own business and has his own family. So the veteran really did not like to rely on his son. He was a very independent person. He has a daughter who lives in Florida. His daughter tried living in Connecticut, but unfortunately her allergies and respiratory issues led her into the hospital almost every time she was here on a IV Solu-Medrol drip. Both the children are married with multiple grandchildren. He continued hunting and fishing until close to the end. And he also enjoyed gardening, though his gardening skills went down in his 80s and early 90s to just a little plot of about maybe 10 by 10 feet. Next slide, please. So due to the recurrence of this disease, the cancer, I should say, and his advancing age, the patient, his wife, and children decided that they would engage and welcome a palliative care consult. This took place in July 28, and happy to say that Sarah is the person who met him initially and followed him through. So at that time, he did inform Sarah that he didn't have any symptoms other than he was frustrated because he wanted his cancer to go away and he wanted to live to be 100. And he also needed another procedure, which meant he had to rely on his son, which he didn't like to do. He had advanced directives in the chart from 2016 that showed he was not sure for several scenarios, and shame on me for not going over those advanced directives during 17 and 18. Sarah did not delve into the larger goals of care at that initial visit due to the patient was really focused on the recurrence of the cancer and the plan for another TACE and what it would mean. Next slide, please. So their journey, September 2018, another lesion in segment 6 and in segment 3. Tumor board, Tamar, as most of you know, run our tumor board here at VA Connecticut. Sarah and I attend the weekly or bi-weekly tumor boards. And this is where we make the recommendations and plan of care. It allows us to all be on the same page as we talk to the family, as we talk to the patient, and we don't give anyone any discrepancies or any mixed results or plans, so that people don't have to have that added stress when sometimes you see them go to primary care, said my cirrhosis is this, and you're telling me my cirrhosis is that. We avoid that with the tumor board. So unfortunately at this time, the tumor board showed embolizing the remaining tumor would likely compromise too much of the healthy liver parenchyma and lead to collateral damage. He then went to oncology in February 2019 and was started on systemic therapy with sorafenib. Unfortunately, the veteran had 2 episodes, one in March, one in April, of acute pancreatitis, presumed to be a result of the sorafenib, and it was discontinued. Next slide, please. So at this time, we needed to really have, a family meeting, and we needed to discuss that further treatment would lead to more harm than benefit, and that actually we did not have an appropriate treatment for his disease at this time. So there was not another option. There was nothing else that we would be able to do, but to now really see where palliative care comes in, where we're going to help manage to help you have the best quality of life, less suffering, and help support your goals and manage symptoms. So the veteran was very tearful, so was his son at this time. We did focus on some of the quality of life, again, discussing let's use the garden, let's continue to hunt and fish as you can, continue to, take care of your wife. She was going through also an episode of a medical illness at this time. And that helped kind of, get everyone on a more positive note towards understanding that we were going towards hospice in the future. And next slide, please. So I saw him in November. He was extremely excited to tell me he got his first deer of the season with his new electronic crossbow. He still was meeting with friends. He still had a great appetite. His son, John, was now stopping by daily, which made him a little aggravated. I still need my independence, but he was really happy to see John every day. Rose is his daughter in Florida. She calls every single day and he looks forward to that. His wife was luckily feeling much, much better at this time and they were helping each other get by. And he said, I'm not moving to Florida. I don't care what Rose tells you to tell me. So they were staying in Connecticut and that was that. March 2020, moving forward, still he was doing some yard work. He was preparing his garden for the spring and his appetite was good. Next slide, please. July 2020, this is when he was admitted with increased abdominal distension and shortness of breath. The CAT scan was performed. It showed significant progression of his known HCC with extensive infiltrated mass encompassing the entire lobe, measuring 21 centimeters. There were also innumerable small lesions in the left lobe as well, and new bilateral pleural effusions. Next slide, please. So prior to us doing a family meeting, I contacted the daughter Rose in Florida, discussed the findings that we had a team meeting, luckily, with Simona at the time, and Sam was a social worker and palliative care works with Sarah. So we made a plan that we did not want to tell this veteran alone in his hospital room what the results were, and that we were going to do a video in his exam room with his daughter and her husband or his son-in-law, who he revered. So we went into the room, we set up the video, and we sat by his side and we explained there were no further treatments or interventions to stop this cancer from progressing. We want to comply with his wishes for end of life. As we've been discussing these for the past few years, we said a prayer in the hospital room. There were tears shed as well. And his goal was to be discharged with home hospice, which happened. Unfortunately, with just 10 days, he was admitted to the VA for inpatient hospice in our Community Living Center, or CLC here. And we were unfortunately, due to COVID, not able to visit this veteran in that time, but he was able to do FaceTime with his daughter thanks to all the amazing staff in our CLC. Next slide, please. So on Sunday, his daughter contacted me to say he passed away peacefully and she had had a smile on his face the night before. So this was at VA Connecticut, came in on Monday. Actually, I spoke with Tamar on Sunday. But the best part from having all this palliative care helped us. All his affairs were in order. And despite COVID, with all the delays for families to undergo funerals, his funeral services took place within 4 days after his passing. We were able to attend the services, and the family just wanted their heartfelt note that this approach with liver oncology and palliative care benefited everyone's needs. Next slide, please. So we are, due to what we see, this patient's story, what you've heard through here, we are in the ongoing palliative care for liver disease study that Tamar also brought up. It is a multi-center study, and it compares the effectiveness of the PC delivered care via the specialist versus a trained hepatologist. And we are in the PC arm. Next slide. So during the patient and the caregiver answer surveys throughout a scheduled timeline. It allows us to see key elements such as the patient and caregiver's understanding of their diagnosis, illness and prognosis, the symptoms and psychological assessment, distress screening and management, discussion of goals of care and advanced directives. The primary outcome of this study is patient-reported quality of life, and other outcomes that are measured are the patient's symptoms and their satisfaction with our care, caregiver burden, healthcare utilization, and survival rates. Next slide. We want to thank you for your attention, and we welcome questions and comments at this time.
If you have a question for any of the three speakers, you are welcome to just speak. I think we're going to unmute everyone now, and you're welcome to pose the questions directly, or if you're more comfortable posing them in the chat box, please feel free to do that as well. I think everyone will join me in saying, wow, what an amazing presentation. So thank you so much, Sarah and Simona and Susan. That was amazing. Thank you.
Thank you.
Thank you.
So I have a question, and it's really, I mean, I think we have a very unique environment in which we practice, because we do practice together. We take care of a lot of sick patients. We sort of have this understanding that this work is a lot of heavy lifting, and we spread it out amongst each other, which is nice. But I think bringing palliative care to general hepatology practice is very daunting to hepatologists because of how much heavy lifting it is and how uncomfortable people feel in delivering this kind of care. And so I guess my question is really focused on Sarah, which is, how do you think it's best that we approach colleagues in palliative care to join us? A lot of it is around staffing, and I think we were just uniquely, you know, lucky to be able to co-localize. But, you know, we have to come at it as at sort of, you know, shared values, and even how would we think about funding a position or that kind of thing if you're in a busy hospital where palliative care is really oncology focused. You know, how would you present that to your hospital administration? You know, what are the metrics you would consider? Just because this has been so hard to do outside the VA, that I'm sure there are listeners who are like, wow, it sounds like utopia, but how do we get this done, you know, in a private, you know, in the private sector?
I think that's a great point you make, Tamar. And I think it's funny, my coordinator of the team, Tracy Shamas, who, you know, really headed up palliative care here at the VA Connecticut about 10 years ago now, started. One good piece of advice she gave to me was baby steps. And I think, you know, we can't convince everybody that this is a necessity. I think finding key stakeholders within whatever organization somebody is in, whether it be a key pulmonary critical care, you know, attendant, or the key cardiologist that you're friendly with and, you know, happens to also share the same values of how important palliative care is. I think for us, that's what we've had to do. You know, I think, Tamar, you have been a key stakeholder. Simona's been a key stakeholder. I know I can think of a couple of oncologists who, you know, also have been true believers from the beginning. But I think just knowing that it is hard. It's an uphill battle. And I think staffing does remain a big issue. Most organizations, I mean, here at VA Connecticut, we're very small. And I think that's something else. Our colleagues over across the street at Yale have over 1,000-bed hospital, and they have more palliative care providers, but there is no way they can be able to target every single unit in the hospital and every single clinic. But I think having the key stakeholders for us has been important, and being able to expand into those clinics. I think the best way to give palliative care to people in the most penetrative way is when we are embedded in clinics. It's really hard to, what I think, make a difference or make impact if we are only consulting in like a general palliative care clinic, which we have done before. But I think us being embedded in clinics and localized like we are here has really been the most beneficial. But it's, I mean, we are a rarity here, you know, which is sad. But I don't know, I don't have a good answer, unfortunately.
Yeah, I mean, I think the other thing, and I really have to give Dr. Garcia-Sau credit for this, is, you know, sometimes you just need people to say, listen, you know, that's not my cup of tea, but do whatever you want to do. And, you know, I think she really was like, go ahead, you know, let's see how it works, you know? So I think that's the other thing. There are many hepatologists who, instead of saying, okay, not my cup of tea, but you know, I don't even want to go there. It was always like, yeah, let's see what happens. And I think, we all feel so much better now that we have palliative care and we can say, this person needs to see Sarah. I mean, I do have to say some of it is just getting over that. Okay, so it's not your cup of tea. Palliative care is not a lot of people's cup of tea. We went into medicine to save people, not to, essentially shepherd them to their end, although that is what we do a lot of the time in cirrhosis. But it's just a lot easier to focus on the disease pathophysiology rather than the emotional and psychological anguish of death. But I think we really need to say, look, there's a whole discipline that does this really well. Just embrace them and it'll be great. And so I have to thank, Dr. Garcia-Sau for saying, sure, give it a try,
Thank you,
So
Tamar.
I
Actually,
oh, I interrupted you, Lupe. How can I do? Chop my head off.
no, I was just gonna say that just today, an ex medical student who was on classroom with me, she remembered me for an episode when we went to see a patient that had -10 days to live, and he was like really sick, and so she was impressed with me because I told the patient, I spoke to him and I said, do you want to stay in this room, and death is near. Do you want to stay in this room? He says, of course, no, I do not want to stay in this room. He said that within hours he was out and he went to a nice place and everything. I said, that's incredible. This is what she remembers me by. So it's sort of my cup of tea, I guess.
I guess so.
I'm glad it rubbed off on you a bit. Well, it's those uncomfortable moments, and I think it brings in our own feelings about death and dying, and
Totally.
what we personally believe, which is all very different. Yeah.
So I have to admit, I always say behind a successful woman is always a man, and behind successful hepatologists is a good palliative care team, I guess. So I think I have my palliative care shining stars. I know I saw them on the line before. I don't know whether they are still there, but when we started our liver cancer scan echo work group in 2012 for Vision 2, we put palliative care as a performance metric. We chose 2-3 metrics to follow, and having palliative care involvement with any cancer, liver cancer diagnosis within 90 days was one of the performance measures. We still look at it as a performance measure. Like when we do the scan echo and a patient gets diagnosed, it's automatic palliative care consultation. So we really recognized it, and the person who taught me that was Dr. Beal. I know he was listening to the talk, but he might have stepped out before we got to this part. And it's him, it's her, and Joanne and Louisa and the whole team that really gave us the encouragement to get involved with palliative care. And they are not physically in the clinic, but they know that Thursday, Friday is our clinics, and they keep their lines open. And the minute we need them, it takes 2 seconds, either through Skype or now Microsoft Teams, text SOS. And who is it coming, and they immediately are there. So we have this since 2012, really. And it's been an unbelievable learning experience. I mean, they've uncovered things that I would have never uncovered during our clinical visits, where we look at values and swelling in the legs and whatever MELD scores, but they uncover so much more by really, and then emails go back and forth encrypted. I think you should give him a call. He's depressed, or his wife thinks like this, and let's look at it and attend it. And there is so much behind the scenes stuff that goes on that's absolutely outside the chart. And that workload is nowhere collected. And our job in all these studies has to be to somehow establish some ground rules so that all that workloads gets collected. I mean, if you look at it, we did a whole day, a small palliative care note, which we cannot even code properly because it's via the phone. It doesn't give you that much RVUs or anything, yet so much detailed work goes into it. So our next thing should be, how can we get the full credit so that we can really hire more palliative care people working with us, you know? And that's really gonna be the challenge. I am hoping, Tamar, that, you know, with your leadership and Vic's leadership and with the palliative care research group, we can answer some of these questions. We can highlight those things. You know, I mean, full disclaimer, my daughter is right now in Colombia doing a palliative care fellowship. And Sunday night, she was on call, and every call that she got was half an hour. It's severe anxiety on the part of family member whose loved one is dying. She goes to the porch, talks to them. Half an hour later, she comes back. She goes, started crying, finished smiling. Mission accomplished, Mom. You know, and how do you, you know, code this? I don't know, you know, and unless we learn how to code this, we are not going to get the funding for this. And we are not going to be able to provide this broadly. I mean, Tamara and I are super lucky, but now our job is to really try to establish some kind of ground rules where we can say, this needs to be coded like this, not only just a 15-minute phone call, but with all the emails that go back and forth amongst the providers. What do you think, Tamar?
ALF has this upcoming initiative to contact our representatives. So I don't know if Kathy wants to say anything about it, but the only way you can change things is
Simona, take the mask off.
Oh, sure.
I can't hear you.
I was just referring to this upcoming initiative from ALF. Let's lobby the Congress and make them pay for what we need.
No, I am telling you, I mean, my son-in-law's mom passed away last year with virtually daily visits to MSK and hospitalizations there. Believe it or not, this terminally ill, single woman living alone, the only support, the son and the future daughter-in-law, did not see palliative care till she got admitted to die to Sloan. Wow. They said, when I asked the oncologist, I mean, how could it be that she has no palliative care? They said that there is too many patients, too few palliative care docs. They are overwhelmed. We are using them only in the inpatient setting. That was the answer. And why? Because they get much more money from the chemo drips than from palliative care visits. So we somehow need to find a way of getting these reimbursed properly so that this beautiful thing can be spread to the whole nation.
That's very well said. Thank you.
Oh, so you guys did a wonderful job. I am here listening and, you know,
thank you.
Music to my ears, Simona.
That's a huge compliment coming from you. Thank you for calling in.
I am sorry that Alice left, you know, I'm really. Yes, Dr. Assis.
Yeah, I have a quick question, which is, do any of you who are participating in the randomized study, or even who are very well in tune, of course, with hepatology and palliative care, know of any models that have been successful, again, in the private sector outside of the VA that are currently existing in tertiary care hospitals around the country?
I'm going to let Tamar answer this.
So it all depends on the local setting. It's so for example, as you know, David, at Yale, they have good presence inpatient, but if you don't have cancer, you don't get palliative care as an outpatient. So it's a start. We have to start somewhere, and at least we can use this opportunity if the patients get admitted in the hospital to open the conversation, but then somebody needs to continue it as an outpatient. So I think we cannot wait until palliative care workforce catches up with us, and that's why it's such a need to have liver providers warm up that, you know, is the right thing to do for the patient, to try to help them in that aspect of not just managing their ascites and the liver care.
Yeah, I agree. And I know that we have huge limitations at Yale where it's only inpatient based. To me, the only way to break that logjam around the country would be to include that kind of request in service lines, really, that get instituted for hepatology and transplant. I mean, if you don't ask for it as part of a larger ask, probably not going to happen.
And when people start asking, then it's going to get more and more broad-based. When people realize that you can even prevent one hospitalization through good palliative care help, which is going to make it worthwhile. But we have to show that. We really have to show those outcomes, really.
This is John, and I work on the inpatient side, and I think we fight that battle a lot with making that, you know, pressing that palliative care consult. I think there's a stigma attached to it, and I think Susan mentioned that earlier. But I think, you know, people are giving up on me, or the family's thinking that, or even caregivers are thinking that. And I just was wondering how you fight that, because I think palliative medicine consults are deferred longer than they should be often.
So it's funny,
somebody who practices.
Go ahead, David. Go ahead.
Yeah, I was going to say, I could speak as somebody who practiced outside the VA. Just a few months ago, I had a very nice conversation with the patient and his wife. The patient was getting worse from end-stage liver disease from PSC. It was in the clinic. Perfect time to bring up palliative care. The patient was interested, the wife was interested, and we were unable to find any suitable services that could be offered for the patient. And so to some degree, frankly, I think the stigma comes when it's thrown upon the patient when they're admitted, but there was not an opportunity or maybe the means to do it earlier on.
No, that's unfortunate, because when you have the family and the patient want to do it and you can offer it, it's terrible. But sometimes we see, so when we discuss palliative care, you get the first sort of blockage. When they hear palliative care, everybody thinks hospice and dying. So that's why we've been using more supportive care as an introduction, and then, you know, they realize they get palliative care. But it was fine. There was an article, I think Washington Post or New York. So basically it starts, the first line starts, palliative care has an image problem. And they do have an image problem. And
that's true.
Palliative care doctors, they are sort of grumbling that we tell them, you know, think about changing the name. So, you know, I think ultimately they will end up changing the name, but it's unfortunate because they think we should do better to educate our patients, and we as providers to be more educated what palliative care involves. I don't think any hepatologist would be happy to be told, okay, we don't like the hepatology name, you have to change your name, otherwise you won't get referrals from us.
I think that at the very get-go, with the initial diagnosis, whether we are going to give them curative care or, you know, whether they are going to be palliative care, at that initial time get-go, to give them a book like what we prepared, you know, liver cancer book that we have. It's in the website also. We give them that book, and the first page of the book is palliative care. It starts with that, and nutrition and this and that, and then goes into all the other treatments. So we give them that book and we tell them everybody gets palliative care. It's not your grandfather's, end of life care. No, don't misunderstand it. This is what everyone gets. We want you to see them. It's holistic care. We want to see what your needs are psychologically, socially, side effect management wise, and then they are, oh, okay, it's a different ball game. But when you approach them just at the end, it's very scary and depressing. They say, oh, my doctor gave me up, I am dying. The minute I say I'm going to refer you to palliative care, I say, no, I'm not giving you up. It's just part of the team. It's if we do it really in a standardized, systematic way, and all of us do the same thing, I think the patients are eventually going to learn. Imagine Lupe saying the whole ASLD, hey, order a palliative care consult in all your patients being diagnosed with this, or once the cirrhosis reaches this stage, everybody will do it. They listen to her. They don't listen to me, but they listen to her, right?
You're overestimating me.
Oh, are you kidding me?
Well, this was a great discussion. Thank you for staying around. It's amazing how many people stayed. It's almost 7:30.
I mean, this is, even though it's a little bit outdated, this is what we give them. And when you open this, like the second or third page is, oh, this is the team, multidisciplinary team. Palliative care is big in it. These are, by the way, our caricatures of my team. And nobody knows though other than us. And overview of cancer, and right at the beginning, signs and symptoms, screening and diagnosis, nutrition, and palliative care, the holistic care part. I mean, if the patient gets this, then palliative care is less scary. So every new diagnosis, we give this book and we say, oh, palliative care is going to see you. They see that this is part of the whole thing. We go over nutrition and everything also. So I think if we approach it like that, they are gonna feel more comfortable. Otherwise, we do have an image problem. Definitely.
There wasn't a opinion on the chat box, but there was a comment that I'd like to share with our speakers. It was from Christopher Woodrell at Mount Sinai in New York City. He says, thank you so much for such a wonderful presentation. That case was so touching and your model is inspiring. And I agree with everything said wholeheartedly, especially the challenge of sitting with prognostic uncertainty. So to you, our speakers, yeah.
Agree.
Yeah, and I'd like to thank the whole group for participating tonight. In closing, this is our first, and it's a great way to start, our new attempt at engaging our community through the ALF MAC events. Please send Kathy, myself, any of us through the ALF Connecticut chapter, any comments, feedbacks on what kind of format would work well for you, what type of topics would prove valuable for discussion on Zoom as the year unfolds. I think we're excited to try to make the best of this situation, and obviously having people engage from around the region and the country is a big bonus. So I want to thank everyone for their presence today.
Thank you.
Thank you. Thank you. Take care, everyone.
Absolutely. Thank you so much, especially to our sponsors again, and our speakers. Thank you so much to Sarah and Simona and Susan. And again, thank you to Sandy and to Adrian and Sherry and Erin, who were with us today from CVS Intercept and Salix. Thank you all so much. And we certainly hope that you join us for our next program.
Thank you,
Thank you, Kathy. Have a good night, everyone.
Good night.
Good night.
Thanks.